Okay. Is that working?
Yes, it is. And it's recording,
Yeah,
isn't it?
Yeah, recording started.
Brilliant, thanks.
Okay. Hi everyone. My name's Oliver. Today I'm going to be talking to you about my project titled The Impact of Observer on Spatial Dose Features in Pelvic Radiotherapy. Throughout, I'll be supervised by Martin. So first, by observer, I'm talking about the radiotherapy professional who's involved in the manual segmentation of the target volume and surrounding organs at risk. So this is usually done using 2D contours on cross-sectional images, and then so you can see in panels A, B, and C here. And then that's usually used to produce a 3D volume, which represents the patient anatomy. So since that's a manual process, there's a lot of factors which can influence the contouring. So these can include observer training, their clinical experience, also whether or not they've received clear organ definitions or guidelines. So naturally, the results are going to vary across observers. If to the right here, we see there's some clear variation in prostate delineation. So this introduces a large source of uncertainty in which has been shown to negatively affect radiotherapy patient outcomes. All right, so with the advent of modern techniques such as IMRT, VMAT, SBRT, I've seen an increase in the precision of dose delivery. Now that precision doesn't automatically translate to better outcomes, since these steeper dose gradients can actually increase the impact of poor contouring. So this image to the right, which I'm sure everyone's seen before, if the dots here represent the dose distribution and the bullseye represents the target, obviously we want the high accuracy, high precision case, but you can see going from low accuracy, low precision to low accuracy, high precision might not actually be a good thing. Especially you can see in this case, you would not be hitting the tumor at all and probably dosing healthy tissue. So yeah, so it's important that the variation in contouring can be quantified to kind of explain this phenomenon. Yeah, it seems very counterintuitive, and obviously that's an extreme example, but the lack of accuracy due to poor contouring so not only would create a bottleneck in improving the outcomes, but you end up with worse outcomes by increasing the precision. So the way I'll be quantifying the observer variation is I'll be using a 5-patient, 10-observer dataset, which contains VMAT and CyberKnife prostate cancer treatment plans. And first of all, I will be quantifying the Interobserver Effects using the variation in normal tissue complication probabilities across the observers. So to do that, first have to extract the dose volume information for all the observer and plan combinations, and then run that through an NTCP model. And then be interesting to compare the results with the of the VMAT plans with the CyberKnife plans. So expect to see increased variation in the CyberKnife plans due to that extra precision. And then after that, I'll basically be repeating that process, but instead of using these DVH-based NTCP variations, we'll be looking at variations in dose surface maps and doseomics. So this work is important in determining the role that interobserver variability has on treatment-induced side effects, which we want to reduce, obviously. So the survival rate of cancer has actually increased over the last few decades, but the quality of life of the survivors, we haven't seen similar improvement reflected there. So some stats. So in Australia, in 2019, we had 40,000 annual pelvic disease cases. At least half of those required radiotherapy. And in that group there, 15 to 20% required hospitalisation due to the side effects. So that puts a lower bound of at least 3,000 hospitalisations due to these genitourinary and gastrointestinal side effects. Now, the direct benefits of reducing the radiotherapy-induced side effect rate would be an improvement in the quality adjusted life year of the patients, which measures both the quality of life and their life expectancy. And then also you get indirect benefits, so say improved tumor control, since you now have more tolerance for dose escalation, and also less strain on the healthcare system, since there'd be less hospitalizations. Okay, so my project can basically be divided into 3 sections. The first will be using 1D dose volume data for the NTCP calculations. The second will be using 2D dose surface maps and seeing the variations there. And then the final stage will involve using 3D features, so doseomics, and looking at what variations occur there. All right, so dose volume information is typically represented as a dose volume histogram. See to the right here is I've plotted ladder DVHs for all the observers in that data set for a single patient. And you can see it does vary. The ways to measure that would be looking at the mean dose, median dose, max dose, the volume receiving a certain amount of dose, but definitely the most clinically relevant would be the normal tissue complication probability. Now, the NTCP model, which I'll be using, is the LKB model. Basically uses empirical data to fit the dose volume information to a dose response curve. So here's the simplest expression for NTCP, and the TD50 and the M are the fitting parameters. So if we look to the right here, if this line here is a dose volume histogram, we can see basically for this patient anyway, they would have a really low probability of experiencing complications. So the advantage of using dose volume information or NTCP models is basically reducing that information to a single number, so which will indicate the potential for side effects. So while it's easy to understand, the downsides are there are some fundamental limitations to the DVH approaches. They mainly stem from the 3D dose distribution getting condensed into a 1D dose volume relationship. So you end up losing spatial information, which introduces the problem of degeneracy. So if you look to the right, we have 3 dose distributions here. They all produce the same dose volume histogram. Now, problem arises where, say, this lower left one would maybe cause certain complication, but the other 2 wouldn't. Then the model fails, and that just emphasizes the need for more advanced spatial models. So one of the spatial models I'll be using, basically using dose surface maps. So that's just the 3D dose distribution along an organ wall being unfolded into a 2D image. Initially, I was using the DSM code package, but I've been running into trouble using that one. So I'll go and have a look at this RT DSM package, which is by the same author, but seems slightly more recent. Okay, so there's 2 methods when using DSMs. The first is basically just a pixel-wise method. So you spatially register the DSMs of all the observers to a common coordinate system, and you look at the regions of localized dose because certain regions are correlated with specific toxicities. The second way is to parameterize the DSM. This advantage of this is you're dealing with less features. An example would be, say, looking at the horizontal or vertical extents of the dose. Okay, and then the final spatial method we're going to use is looking at the variation in doseomics, or the spatial texture features that we extract from the 3D dose distribution. So I haven't got into this stage yet, but I tend to use high radiomics because that can handle the first order features, mean, median, max, interquartile range, gray levels. Can look at the shape of the distribution without kind of independent of the dose intensity. And it can also handle gray level co-occurrence matrix and gray level run length matrix, which they're 2 doseomics which have had some strong results predicting lung complications. So that'll be interesting to see. Now, so in these models, you have to account for the random errors associated with setup error and patient and organ motion. So luckily, there's some work by Van Herk, which basically has found that the probability distribution of these errors is Gaussian. So luckily that means we can convolve the dose distribution with a low pass filter to achieve kind of the same end result. To finish up, I've included a table of some similar Interobserver Effects studies ranging back a few decades. I just thought I'd illustrate kind of the progression of the research in this area. Started off mainly looking at the structures, comparing between the volumes or the extents of the structures. But that problem with that is there's no real clinical relevance there. But the focus then seemed to shift to looking at dosimetry and radiobiological metrics such as NTCP or your dose statistics. So the problem here is you run into the limitations of the dose volume approach. So here we are now, where we can look at the impact of observer on spatial dose features. And DSMs and doseomics are just two examples there. All right, thank you for listening. I'll try my best to answer any questions.
That's great. Thanks, Oliver. It's a great presentation. Brilliant. Any questions from Oliver?
I've got a question. Oliver, great presentation. Thanks very much. Can you comment on the significance of your project?
Of my project? Okay, so to go back, basically, we're looking at new ways to quantify this interobserver variability. So it has been done before using, as I mentioned before, dose volume methods, but there isn't too much in the way of looking at spatial dose features, which just has that extra information that's missing. Does that answer your question?
Yeah. So how do you think your method would, I guess, impact like clinically? Do you think there is a clinical impact there?
Well, okay, so it really depends on what's found. Say, for example, you did see that interobserver variability, there's just massive variation there. Then obviously there would be an increased need to reduce that because it would be the dominating factor in kind of these bad patient outcomes. So, you know, there might be more strict guidelines in the contouring process or more research into automatic segmentation, that kind of thing.
Great, thank you.
Brilliant. Any other questions from Oliver?
Can't let you get away that easily. Just one question about the dose surface maps.
Yeah.
So when you're looking at the difference between observers and the effect on the dose surface maps, how do you think you might quantify that difference?
Well, it depends what method you're going with. If you're going with pixel-wise methods, you would basically just look at where the dose is more localized on one map, and so I guess you could you'd calculate the distance between these localized regions. Or if you're looking at the second method of parameterizing DSMs, obviously then you could just directly compare the numbers. You know, if you're comparing extents, you could look at the standard deviations there.
Okay. Any other questions from Oliver? So Oliver, lots of work need to be done. So really good time plan is needed. Good planning. All the best. Thanks very much, Oliver.
Thank you.
So you can stop recording.